Good afternoon and welcome back. I'm Lauren Hardin, one of the co-chairs of PTAC. And in this session, Relationship Between Payment Features and Care Transition Innovations, I'm pleased to welcome three experts who have experience with how payment features can encourage some of the innovations we've been discussing today. You can find their full biographies posted on the ASPE PTAC website, along with their overview slides. I'll briefly introduce our guests and give them a few minutes each to share an overview of their key takeaways. First, we have Ms. Sherry Latimer, who is the Executive Director at the National Transitions of Care Coalition. Welcome, Sherry. Please go ahead.
Thank you so very much. Hello, committee. Good afternoon to you, or if you're in my part of the country, it is still good morning. I'm on the Pacific time zone. And thank you for allowing me to just share a few thoughts around care transitions and payment features. As we talk about really the next slide, the role of transitions of care, I don't think there's anything new here, other than I think many of us find that been addressing some of these issues for the last 20 years, we still are struggling with that transition from one healthcare provider or setting to another, often related to just communication and the sharing of information. I always think about the saying that Dr. Eric Coleman shared with us at one of our first meetings in 2006, that transitions of care is not about an individual, it is a team sport. And today, when we talk about team sports in transitions of care, we have to talk about the teams between each level of care, between each communication point. Those barriers we see are still the barriers that were identified in 2006 working as the National Transitions of Care Coalition. System barriers that often lead to poor communication, not being able to share information, it's not timely, it's not presented in a format, it's not complete. Or clinical barriers where we are not sharing and communicating with providers at each level of care. The transfer of information often is delayed. Lots of times there is duplication of ordering of medications. And of course, at our patient level barriers are still health literacy, an understanding of not only the health illness that they're dealing with, but just the care coordination that is required across the continuum of care. The next slide is one that I think really highlights what we're talking about, in that in the center of all that we do is our patient and their caregiver, their identified caregiver. Yet they move through a huge continuum of care, as you can see. And in that continuum of care, that sharing of information is not with just one provider. It is multiple providers, multiple levels, and the more medically complex the patient's diagnosis is, the more that we see this transfer of not only the patient and family to a different level of care, but through multiple individuals. The next slide very quickly highlights, this was developed by NTALK, and this was just revised in 2022 to really highlight some of the things that we have accomplished, but still need to consider. If you look at these areas around designing transition, you'll notice that many of them are included in the National Quality Strategy, in CMS's framework for care coordination. And yet we are still struggling to highlight some of these. I think among those is around our medication management and services and coordination. We're talking about not only having good physician-provider involvement, but pharmacy involvement, where it isn't just about reconciliation. It is about counseling. It is about education. It is about coordination. It is helping families and patients really ascertain the medications that they need, and understanding what some of these transitions from such as acute care to post-acute can actually mean around medications that were ordered at the hospital and yet may not be followed through in the post-acute component based on formulary changes. Transition planning, which is so important and so timely, and information transfer. We are still dealing with 40 to 45% of the time, primary care physicians don't even know their patient was admitted to the hospital. And if the patient would call, that would be the first notification, and they would not have the information from that transfer. So there are a lot of areas that are really key to identifying and really helping us us understand the coordination that is needed, not only in communication, but also around reimbursement for the services. The next slide, I wanted to just highlight very quickly a key piece that the National Transitions of Care Coalition has really been working towards, is really understanding that the assessment process that is needed is a combination of the three areas where we see huge gaps and barriers around the physical health, the mental health, including the substance use disorder, and the social determinants or social needs of health. To assess one without the other often leaves a gap and barrier. We call this the triune because it is really important that we highlight some of these factions and that we really understand the correlation in treating the whole patient and the family caregiver through this process. So let's talk just very quickly about what are some of the reimbursement gaps and barriers that our providers, our patients, their family caregivers, and some of our payers are actually identifying. The next slide, please. We often, as I said before, find that timely notification and information to providers at that point of discharge and transition is delayed. Now, I do want to highlight that where we have accountable care organizations and inclusive services with physicians, we see better notification. But in our Medicare and Medicaid fee-for-service world, this is often a significant delay in really identifying the needs for the patient. The coordination between the specialist and the use and the PCP and the use of the TCM codes is often confusing and sometimes is not used at all because only one provider can bill. And so when I look at transitions of care, and the NTAC looks at transitions of care, we understand that our very medically complex patients aren't going to see just one provider. A stay in the hospital and a transfer of that patient, transition of that patient to either home or post-acute often is going to involve several specialists plus the primary care. And as I said before, oftentimes our PCP is not notified about that admission. Some providers are still talking about the reimbursement codes don't cover the administrative costs, the documentation and billing, plus the services that are being provided. Timely access and appointment to PCP and specialists for follow-up care. Depending on where you live geographically today in the U.S., that may be very, very difficult, especially if you are not and haven't identified a primary care or a specialist. If you are in a rural area, that timely access is probably going to be even more difficult. I live in the northern part of Arizona in a small community where access to primary care physicians is often delayed. To get a new appointment to a primary care in the area I live in is often 8 weeks to 2 to 3 months before you can get that appointment. So if those care coordination issues are not identified, then there are definitely delays and there will not be consistency of treatment. We talked about the TCM codes used only by one provider during the 30 days after discharge, and I think there is oftentimes confusion among providers who should use those codes. Medication reconciliation and management, not just reconciliation, but management, also really requires our pharmacist support, but oftentimes we don't have the pharmacist in this equation, and especially in these transitions. Transition follow-up with patients and their family caregivers at discharge is often not clearly identified. And if we haven't done a good assessment around do they have transportation, are they connected to the physician, do they have an appointment before they go, that confusion can only grow. I did talk about how the TCM and the CCM code coordination is not prominent. Since one provider must use these codes, yet we ask a care team among the various levels of care to really interact. So we're not talking about just one individual or one specialist. I think of clients such as the one I will just share with you, who is a diabetic, has cardiovascular disease, is obese, has pulmonary issues, and was just identified with cancer. When we think about the number of providers that will be involved in this individual's care as we coordinate care, it is key that we understand that these codes don't really coordinate the collaboration of these teams across the board. Patient assessments need to include all aspects, as we talked about. And I do want to highlight that the TCM codes versus fee-for-service, as I said before, in ACO's IDS's value-based payments, this is often seen to be used more frequently, still not to its full extent. But in the fee-for-service world, this is really difficult, especially when electronic health records are not connected with independent physicians. And accountable care providers who can bill for TCM and CCM, since that is limited to physicians, DOs, and advanced practice nurses, this again has a limit to it. So I'd like to leave you with just a few suggestions as I close. The next slide highlights some of those for your consideration, is to look at, can we enhance the TCM code so that it does support more than one provider. One of the things we talk about is the hub provider. When a patient is medically complex, have we decided that the hub provider is a PCP or a specialist? Whichever that is, there should be that code for the TCM, but there should be a secondary code. If the PCP is the hub provider, but a specialist is involved, then the code needs to support both coordinating care. We also need to look at, can we ease the requirements for billing? And to enhance CCM after TCM is, should we look at developing a bridge code for the handover from TCM to CCM coordination and expand those CCM codes for more than one provider so that we are really supporting collaborative practice and care coordination as a team across the continuum of care. I cannot stress enough how our medically complex patients get lost in a lot of this process. And especially if we're going from acute care to post-acute care to then home to rehab, back to the hospital, this care coordination really needs to be tied with some type of coordinated reimbursement. I would like to suggest we look at integrating pharmacists in part of this CCM reimbursement. I'm going to skip to that last one real quick to talk a little bit about collaborative practice agreements. We're hearing from those individuals, pharmacists and often case managers who are working under collaborative practice agreements, that often these are not structured. The individuals doing the service and the work are really paid less than those that are doing the administrative billing. And that's another point to really look at. Do we need to structure some of these differently? I'd like to also recommend an additional expansion of providers of care, from our pharmacists to registered nurses with bachelor's and certification in case management that are able to help coordinate this. We do not have enough providers, especially in the rural areas, to be able to provide these services, and that expansion would help us not only support patients, but to be able to give the quality of care that patients deserve no matter where they are in the United States. I also recommend that we really look at how we can support advanced practice nurses, especially in these rural and underserved, what we call medical deserts, that can really provide, because sometimes it is an advanced practice nurse and a pharmacist that are the only key folks that are available. We do hear from our pharmacists that in some of these rural areas, the pharmacist may be the first contact for primary care. I want to thank the committee for allowing me to share these thoughts, and I look forward to your questions after the presentations. Thank you.
Thank you so much, Ms. Latimer. That was really valuable presentation. Committee members will have time for questions after the third presenter is finished, so please write down your thoughts. And I'm going to next go to Dr. Diane Sanders Cepeda, the Senior Medical Director at United Healthcare Retiree Solutions. Diane, please go ahead.
Thank you, and thank you all for having me today. It's a wonderful experience. I want to talk about the relationship between payment features and care transition and really delve into some innovations. So if we go to the next slide, our focus today will be to address barriers impacting care transitions, really talk about the infrastructure and challenges that we see across the post-acute long-term care continuum, and consider some innovations such as provider partnerships and innovations around care delivery. When if we go to the, thank you, if as we are looking at this slide, I really wanted to showcase what the true landscape is when we talk about post-acute long-term care and that continuum. It really does focus in on those members as they're moving out of the hospital to those different post-acute care settings, which are inclusive of acute inpatient rehabs, long-term acute care hospitals, our home health, and where I'm going to focus today, the skilled nursing facility. When we think about the long-term care settings that we are often delivery care, that could include the more traditional nursing home, which is still in within a skilled nursing facility, that assisted living model, and definitely care in the home. So we wanted to make sure when we're talking about this that we're really looking at how do members and patients move across this continuum? What services are available to them? And really think about those challenges. What the previous presenter presented was really those issues around the transitions of care. And I think we all feel that. We are all experiencing that. And what we've noticed in the post-acute long-term care space is those patients coming into this space are often sicker, requiring more needs and more services. So if we move to the next slide, one of the challenges that we're seeing with our nursing facilities are around not only where they're located, there could be a intense amount of variability. If I'm talking about a facility that's at a suburban population versus urban or rural, the hospitals that they are surrounded by, those places where we're looking at who are they serving, where are they emitting from, that has a huge challenge, not only because it could mean variability among the payer source, but just in access and what they're dealing with as far as those social risk factors that may be impacting certain populations over others. And then I like to mention the competitive landscape. If we think back to the slide where we're looking at that whole landscape, there are a lot of people competing for these residents, these patients as they come out of that acute space. So when we're thinking about that pressure on the skilled nursing facility in particular, they are competing with other skilled nursing facilities, acute inpatient rehabs, and sometimes those long-term acute care hospitals for that same population. And then where I want to dwell a little bit on is the payment models. What we are really seeing and thinking about as we are looking at how do we support and really delve into the challenges that our skilled nursing facilities undergo, really have to think about how do these facilities get paid. When we talk about this, a lot of people assume that it's really that Medicare Part A benefit that's supporting these buildings, but most of the dollars for our nursing facilities are coming in from Medicaid dollars for that long-term care component. So when we look at how the Medicaid payments, that varies truly state to state, and how much a facility may be reimbursed. It can vary county to county as well. And so that is a part that a lot of SNFs are having trouble with. There's also now we're seeing more Medicare Advantage beneficiaries, similar to the program that I work in, where they pay differently. They require different levels of authorization. Those pre-authorization processes may lead to delays, and those are things that our facilities have to deal with, as well as different models like the institutionalized special needs models and the institutional equivalent special needs programs that exist now. Those programs actually do have a benefit too, and we'll talk about that as we move through the presentation. Where I would like to go is really into the barriers. So it was mentioned a bit as we're thinking about those transitions of care. what barriers and what resources are needed, and what do we try to overcome. When we're looking at the skilled nursing facility space, we do know that there are a ton of lack of resources, one being bed availability. This is changing on a day-to-day basis, depending on the staffing that we may see, depending on those shortages in those areas. And from different areas in the country, we're going to see different needs. For example, the urban population versus the suburban versus the rural. We're having very different challenges when it comes to staffing. And I have staffing shortages up there. And if you look at that graphic, what we've seen is that when as the healthcare sector was rebounding following those early months in the early years of the pandemic, we saw that we had rebound in most of the health sectors except for the nursing facility and those residential cares. Um, this is what we're still dealing with. This is the problems that we're still having. In addition, there still remains technology challenges, such as the fact that our EMRs do not speak to each other and we can't share data back and forth between an acute care hospital, and it really becomes a challenge when so much of all of the information being shared is still on paper or via fax. The fourth thing and I have questions around it because there's a lot of variability. I used to say, as I assessed facilities with the iSNP that I once worked with, that if you saw one sniff, you saw one sniff. So from building to building, location to location, even if that facility is part of a chain, we are still seeing huge variability in the way they are doing their executing on their daily processes, interacting with their staff, interacting with the clinical staff. And I think that what we are often not appreciating is how the clinicians are in those facilities as well, the role of the medical director in those buildings. So all of that becomes a issue that we have to then overcome when we're talking about nursing facilities. If we go to the next slide, looking at how we're utilizing transitional care management and those codes that we have available, I will say that when we're thinking about this population of providers who care for residents and patients in the skilled nursing facility, that there's a lot of variability when it comes to utilization of TCM codes. What we find often is that this is something more around the ACOs and those value-based care models. A lot of the independent clinicians, they don't understand or have the time to utilize these codes. So even though this study that was out of the Journal of American Medical Association, looking at the findings from 2013 to 2018, saw that there was an increase. If you look provider to provider, you'll see that those increases were really around those entities that have a larger structure and are able to organize a code and understand that coding differently than those independent practitioners. If we go to the next slide, I want to just share when we're thinking about where do we need to go and how do we provide innovation in this space. One thing is around the provider partnerships, thinking both of the provider as the clinician and as the SNF. We are able to look at how do we incentivize and partner differently with these facilities. Those models of care, such as the iSNPs and the IE SNPs, they do allow for more of an incentivized structure where a facility can be bonused, providers can bill differently, there can be different engagement, even to the point of one of the more popular features of our public health emergency where we had that 72-hour stay waived for SNFs. Under those care models, they already do that waiving, so that was not something that was taken away. When we look at providers, I think that this becomes something that on the value-based care side, a lot of Medicare Advantage plans have done really well in thinking about how do I partner and provide incentives beyond the transitional care management coding to providers who are actively doing the process. So one thing that we've been able to implement for both those providers who are par and non-par is incentives around quality. So looking at, do you have a coordinated discharge with the patients that you're serving? How frequently are they back into your office after discharge, and those things? But none of that works without care coordination. So to the point made earlier, there needs to be extensive care coordination and delivery of care in order to get to a point where we are getting that person who's been discharged from the hospital back in front of their PCP. And what we've seen, especially after a SNF discharge, is that it is very disconnected. So providing care coordination, whether it's a nurse or a social worker, helping that member as they're moving through that journey, navigation, where we're looking at their medications and doing a full assessment of their medications, because we know that there's so many variability between the formulary at the hospital, the formulary at the SNF. That becomes a vital component when we're thinking about how do we innovate in this space. Something that I've been able to really design and lead with are in-home care services and support. We know that when patients come out of the hospital, come out of the SNF setting, they may be in need of things as they've experienced functional declines. A lot of things that drive a person back to the hospital is not just, oh, I didn't take my medication, and maybe I didn't have the ability to pick up my medication. So what other services can we do to make sure we're helping that person in their home as they're transitioning back into their home? I do believe that if we're going to talk about social risk and doing assessments of social determinants of health, I need to stand up something to support that. And what we've been able to stand up is really post-discharge meal delivery to the home. In 2022, we had 12,000 members, and we were able to deliver over 344,000 meals to them in that post-discharge period. So really looking at how do I get in front of those social needs and risk so that we could get that member or that patient healthy and keep them at home and out of going back to the hospital. And I will stop there and just thank you for this opportunity, and I look forward to your questions.
Thank you so much, Dr. Sanders Cepeda. Another really interesting presentation. I'm sure our members will have many questions for you. And finally, I'd like to introduce Dr. Diane Meyer, who's the founder, director, emerita, and strategic medical advisor of the Center to Advance Palliative Care. Welcome, Diane. Please go ahead.
Thanks so much. It's really an honor to be here. I appreciate the invitation. I'm a boarded geriatrician and palliative medicine physician on the faculty at the Mount Sinai School of Medicine, and also work with the Center to Advance Palliative Care. Next slide, please. What I want to focus on is the subset of high cost, high need Medicare beneficiaries who have serious illness. And just so that we're all on the same page, this is the definition of serious illness: a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. So you see here that in this definition, it doesn't say anything about prognosis. It says high risk of mortality. Next slide, please. So I noted in the materials that were sent to me in preparation for this session, the repeated use of the phrase transitions to palliative care, comfort care, or end-of-life services, which falsely equates the three terms and yields the opposite of the intended result. That is, it drives patients and clinicians away. To the extent that palliative care is conflated with comfort measures only, or hospice care, or end-of-life care, it leaves the table of the treatment options for that patient. Palliative care, as defined by Medicare, is specialized medical care for people with serious illness, focused on providing relief from the symptoms and stress of the illness. It is an added layer of support working in partnership with other providers, and is provided at the same time as curative and life-prolonging treatment. Nothing in this definition includes stopping treatments, and access to palliative care is based on patient need, not on their prognosis. Next slide, please. And again, here's the CMS definition with a graphic showing over time patients' need for and the varying ratios of disease-directed therapies and palliative care, showing that palliative care is delivered at the same time as disease-directed treatment. Next slide, please. So here's an example from the bundled payments for care improvements in a subacute rehab setting, where, as I'm sure you are well aware, a high percentage of subacute rehab patients die within 6 months, 28% within 1 year. And this is a quote from the person who was running that bundled payment program there. They used an embedded palliative care consultant within their subacute rehab. And she said, the only way we were able to sell the idea of the embedded palliative care consultant to clinicians was that it's not giving up and it's not end of life. Next slide, please. So what many people are not aware of is that the majority of high-cost, high-need patients are actually not dying and are not near the end of life. In fact, only 1 in 10 of the highest cost, high-need patients turn out in retrospect to have been in the last year of life. Half have short-term high needs. So, for example, someone who has a coronary artery bypass grafting and then is discharged and returns to reasonably good health, or someone who has a kidney transplant and then is discharged and returns to reasonably good health. 40%, the next largest group, have persistent high cost year over year. And that group is characterized by cognitive impairment, functional impairment, huge family caregiver burden, symptom distress. And if we impose a prognostic criterion there, we miss that entire 40% group and a big chunk of the 11% as well. Next slide, please. So untreated symptom distress increasingly drives emergency department and hospitalization use. And these are data on cancer ED visit primary diagnoses within the top 10. 27% of cancer ED diagnoses were for pain. And in the 10 years between 2012 and 2019, there was a 100% increase in the number of patients with any illness visiting an ED because of pain. And you can understand why people visit the ED because of pain. What may not be so clear is that the rest of the system, primary and specialty care, just doesn't know how to manage it and doesn't manage it. Next slide, please. This is a patient I've been taking care of for 11 years. Her name is Debbie. And I have her permission to use her image and her story. When I met her, this was her when I met her. She was a hairdresser who had been recently diagnosed with multiple myeloma, went through a successful bone marrow transplant, which was complicated by severe and disabling nerve injury pain. Next slide, please. So she eventually reached palliative care after she was in the emergency department 4 or 5 times for disabling pain. Somebody finally called a palliative care consult. She was having depression, functional decline, inability to work, social isolation, lots of suffering, multiple 911 calls. And one of the things that was most painful to her was that each time she came to the ED with this pain, she was labeled as a manipulative drug-seeking patient. Happens a lot to Black and African American patients. Once palliative care got involved, we were able to control her pain. It took a while to get it under reasonable control. She was able to return to work part-time. She has 24/7 access to our team. So if the pain is getting worse or some problem arises, she can reach us. She has an ongoing relationship with her. We see her about once a month. She sees her hematology team maybe every quarter or every 6 months. because we are an interdisciplinary team, she gets support from our social worker, our chaplain, our yoga, and art therapists, none of which are reimbursed on the fee-for-service billing. And she has not once made a 911 call or been back to the ED in the last 10 years because the system is now, what we're providing is matched to her needs. And she is not dying. She does not have a recurrence of her myeloma. Next slide. So integration is what we're seeking for palliative care, not a transition from curative care to palliative care. Most serious illness is chronic. Most people with serious illness are not dying. And in case you need reminding, nobody is interested in dying, and everyone wants treatment that might prolong their life or improve its quality. And this is especially true for minorities who have traditionally been excluded from care in our healthcare system, and for whom the suggestion that they might not want life-prolonging treatment anymore is perceived and experienced as a racist exclusion. Next slide, please. Alternative payment models implicitly incentivize palliative care, but not explicitly. And many providers have been very slow to connect the dots. And this is a health affairs paper from 2019 that looks at the number of steps that APMs have used to try to manage their high need, high cost population. And you can see the vast majority of them identify the high need, high cost population. Many fewer, under 20%, are doing routine advanced care planning. Many fewer have 24/7 access, telephone access for their patients. Only about 20% have hospital-based palliative care routinely available, and even fewer have a routine availability of community-based palliative care. So even though these people are at risk and taking risk, they have not utilized this proven strategy. Next slide, please. So my point, again, the great majority of these patients are not dying. The goal should be early identification of these patients, 90% of whom are not in the last year of life. And the population includes about 80% of Medicare beneficiaries who are hospitalized. Most skilled nursing facility and long-term care facilities would be eligible. And in primary care, it's about 10% of the total patient population that would fit this criterion. Next slide, please. So these are the criteria for palliative care needs for screening. And you will note that diagnosis is not listed here. I have lots of patients with lung cancer who are working full-time. They do not need palliative care right now. They're functioning well, they feel well, their disease is under control. But these factors are consistently valid predictors of high utilization and repeated utilization. Functional and cognitive impairment, symptom distress, caregiver distress, frailty, social drivers of poor health, psychiatric and substance use disorder comorbidity, and recurrent utilization, hospitalization, and ED visits. Those screening in should have mandatory palliative care consultation and/or co-management, and quality measures that reflect, and incentives that reflect the proportion screened and referred. Next slide, please. So the barrier between high-value care transitions and palliative care is precisely this misconception that conflates palliative care with comfort measures or end-of-life care. It is the surest way to reduce access to palliative care is to conflate it with end-of-life care. And as you know, discharging patients from hospital to post-acute, subacute rehab without prior clarification of achievable goals for care is often a very low value care transition. 70% of patients with cancer discharged to a subacute are dead within 1 year. 64% of patients with stroke discharged to subacute rehab are dead within 1 year. In the other non-cancer groups, it's about 25%. And that's where you see these articles on rehab to death, because the subacute rehab is paid more, the more rehab it provides, even if the patient is dying. Next slide, please. So our recommendations are that we use the new NQF-endorsed patient-reported outcome measures, patient experience of feeling heard and understood, and patient experience of receiving the desired help for pain as measures of the patient experience with transition management. We recommend explicit requirements and payment incentives for screening for and referral to palliative care from the ED or during hospitalization, and that we start requiring access to palliative care specialists and screening for needs in all relevant settings. Next slide, please. And in case you think that's just not something CMS can do, it did it with left ventricular assist devices. CMS requires the presence of a palliative care specialist on an LVAD team. None of us know how they came up with that idea, but they did it. And there was no objection to it, and it is happening across the country. So why not in other settings? Next slide, please. So the main takeaway is that a strong evidence base indicates that palliative care delivered from the point of diagnosis well before a patient is near the end improves quality of life, reduces caregiver and clinician burden, and reduces avoidable utilization. In contrast, linking it to hospice or end of life results in markedly reduced and delayed utilization, both because many of these patients are not dying, so they shouldn't be shifted to a care program for the dying, and because nobody wants to be so labeled and people want to live as long as they can. So we need to stop linking palliative care to transitions away from traditional treatment, and we need to add mandatory screening for palliative care needs, referral, and inclusion of specialists in the care of those who screen in as high need, high cost. Next slide. Thank you.
Dr. Mara, that was incredibly helpful. Thank you so much. We're going to turn next to an opportunity to ask questions. We have until about 2:40. I'll start us off with one question, but PTAC members, if you have a question you'd like to ask, please turn your table tent with your name upright, and I'll call on you as those questions arise. So one thing that's really important as we look across settings and care transitions is really the integration of health equity and health-related social needs. And each of you have touched on that, but I'd like to give you each an opportunity to go a little bit deeper. If you were going to make recommendations to this group about what should be considered as essential in addressing health-related social needs, what recommendation would you have for the group? And whoever would like to go first can start.
Well, if no one else is ready to start, what I will say is that the most valuable member of our team is our social worker. And Medicare fee-for-service doesn't enable support of those people. Without a social worker, we cannot reduce utilization, no matter what we do medically or spiritually or from a nursing standpoint. If we can't find safe housing, if we can't organize transportation, if we can't figure out a way to get the meds paid for, that patient's going to show up in the ED because that is the only place that has to take care of them. And the failure to recognize the essential role of social work in addressing social drivers of ill health is one of the key faults in the traditional Medicare program.
This is Sherry. I couldn't agree more, Doctor. And we not only see the value of the social worker in these instances, but of the certified case manager, be it nurse or social worker, who really understands the need for coordination and resource. And unfortunately, in most cases, they are not paid for either. And so they are often looked as a cost center rather than a revenue center. And yet in the long run, they help improve the quality, the consistency, and are the advocate for that patient and family caregivers. So the National Transitions of Care Coalition has pushed forward heavily with social work and nursing involved in case management and in these social needs to address them because again, I will quote a favorite of mine, which is Dr. Coleman. He said 50% of his readmissions at this point in time are often related to the social needs assessment that wasn't done rather than to the clinical care plan that was developed.
So I definitely will pile on to both of those comments about social workers and the need that we have and in our skilled nursing facilities and across the post-acute care continuum. I think that one of the advantages that we've been able to really look at on the payer side is how to stand up some of those things where we do have more social support and caregiver support being delivered to those members of those programs. But what I would ask and recommend is for us to think a little bit broader and really look at what is driving the outcomes and look at where the members and the rather the beneficiaries of Medicare fee for service, what are their needs in their community? How are we addressing those needs? Because if I have someone who's living in a food desert, and we can tell, we can go to look at what's going on at the level of the zip code. That data is available to all of us, but how are we utilizing it? How do I send a person home to homelessness? And then if I admit them into a SNF, what happens thereafter? I think those are the bigger questions that we need to be asking. We need more boots on the ground, so we definitely need more licensed social workers in the nursing facilities doing this work. We need to support it better. I think I can speak from my own experience of always being in the social worker's office because we had those difficult cases where we were trying to discharge a person and we knew there was no caregiver support in their home. We knew that within 3 days, if we didn't get this set up correctly, they would be back in the hospital. Um, I've been able to go into a person's home to do a home visit and see that their refrigerator is empty, see that their home lacks security, that they are tripping over items, yet I can't get anyone to come in and do the cleaning and that support that they may need. That doesn't seem like it's medical, but in the geriatric population becomes very critical to keeping a person in their home and keeping them safe.
Thank you so much. Valuable comments. So I think, Larry, you were first.
Well, my question's for Sherry, and everybody on this committee knows how happy I was to hear you say that we should be able to pay multiple TCM codes. But you didn't mention PCM codes. And so you talked about TCM and CCM, but since the beginning of last year, specialists can bill for a PCM code, which only requires one chronic illness. Could this be a solution for the specialists to help coordinate their component of care in the post-hospital admission period?
I think that the application of the PCM code is at this point still somewhat misunderstood. When you apply it, when you don't apply it, and to what patient versus the patient that may fall under the TCM and the CCM. I think what we often hear is the confusion around these codes and the integration of how these codes might work together. So there definitely needs to be some clarification on that. I do honestly believe that the application of the PCM code could be expanded when you have that patient that has multiple specialists plus the primary care. I do get concerned on who is going to be considered the hub. Who is the one that is going to really have the full oversight of what we see? I go back and I look at programs that CMS has put in, and you can see the program by disease state. So it still is siloed by that disease state. How do we integrate that when your patient has 5 of those chronic diseases integrated and coordinate that? Who takes that responsibility as hub versus the specialist, and how is that really couched in reimbursement? I wish I could give you an answer that I think is, the best thing since sliced bread, but we constantly talk about this at NTALK. We do know, and I do want to stipulate that as a provider care team across these continuum of services, we have not used our pharmacists as we should, which helps coordinate this multi-polypharmacy issue that we have. And they have, under their medication management services, a broad breadth of services that can be integrated. And so as we talk about TCM, PCM, TCM, I encourage you to look at it. How do we incorporate that pharmacist as a provider of care in there for the specific aspects? And I know in some cases that is somewhat threatening to individuals, but we're at a point where the shortage of our providers is so great across the board in primary care, in our pharmacy case management. And I'm going to say this because in health equity, I believe this. We need to have the cultural and racial representation in our workforce to work with our patients and their family caregivers. It's one of the reasons I love the healthcare worker that is in the community, because oftentimes they are able to relate to this. So I know I kind of went on the one side, but in answer to your question, I do think PCM gives us an avenue, and I think we need to see how we can incorporate that and integrate it with TCM and CCM across our care teams.
Dr. Meyer, Dr. Cepeda, did either one of you want to also comment?
I support what Sharon said.
Yeah, we agree.
Yeah, totally.
Excellent. We'll go next to Angelo.
Yeah, thank you. So this has been a great conversation, and what I visualize sitting here looking at the three of you as you talk, you really described a very integrated model between the three of you, and a very complex matrix of care for very complicated patients. And what I'd like to ask, maybe starting with Dr. Meyer, is in what you all have described, how specifically do you partner with and integrate with primary care physicians, or do you?
Yeah. So in the ideal world, very regularly. So we're a health system that has an electronic health record that has a chat function, and we are constantly updating one another between the multiple specialists who are caring for our patients, our palliative care team, and the primary care doc. And that sometimes daily communication through Epic Chat has revolutionized the ease of communication because it doesn't have to be synchronous, right? We don't all have to be on the phone at the same time. And it really makes a huge difference. Where it breaks down, of course, is when the person we're trying to communicate with is not in our system. And many of our patients are getting care all over the place. Or if the patient is in a facility, those people are not. I don't know if health policy can fix that brokenness of electronic communication around healthcare, but it is a major barrier to improving quality and controlling cost.
So I can jump in next. I'll say that from where I sit is a little different. We have now 1.8 million retirees as part of our group Medicare Advantage plan, and they are across the country and in the Virgin Islands, Puerto Rico, and Guam as well. So there is a lot of diversity in around who we are providing care for, as well as the providers. The way our infrastructure is set up, we are trying to not only identify those primary care physicians from the members of the program, but any information that we're getting in where it identifies that this is a person who is working as a provider in our plan, we're then trying to get in front of them as far as meeting them in their offices, going out, doing virtual visits, and working with them to become part of what we call an incentive program, where every time they're meeting these quality metrics, we are including them in that bonus that we may get from meeting that star measure. So they are also incentivized. We've been doing this now for over 5 years, and it has worked very well in those markets that we serve. We still though see those barriers around people not being attributed to any primary care position who you may find when they initially meet it go to the emergency room. So one of the programs that we've stood up is really trying to get in front of that person and get them a virtual visit, at least if not an in-person visit, with a primary care provider within 7 days of that presentation to the emergency room.
Sherry, I'm interested in your insights.
I'll just add what I think is probably pretty, what do I want to say, easily identified today as we look at this care coordination. As I had said in my presentation, when we see ACOs and IDNs and Medicare Advantage plans, we see better coordination. We are struggling, and there's just no doubt about our primary care physicians in a fee-for-service world who are independent physicians being inclusive in all of this care, in notification, in trying to coordinate. I can share my age with you all by telling you that when I first went into ambulatory practice back in the early 70s, it was general practitioners. And believe me, they were the hub. They were the coordinator. They did everything. The doctor I went to work for was the surgeon and delivered babies and across the board. We don't have that today. So to try and coordinate these individuals is difficult. I do believe, though, that by incentivizing the impact of value when coordination is given when patients are in the hospital and transition to that next level of care to that primary care physician, especially if they are linked and they have identified them. That is key in the fee-for-service world of starting to try and pull this together. In the rural areas, it's going to be more difficult, but our primary care physicians that work with us often are linked to, as I said, ACOs, Medicare Advantages, but those that are independent constantly struggle with that communication about their patients.
And if I can jump back in for a minute, just as a person who came from that independent practitioner role, being a geriatrician in the community that I served, it was difficult then. It remains difficult when you're doing that assessment and getting that information from the hospital system. If it wasn't for trying to get in front and making sure every person who came into my office knew, if you go to the ER, I want to know, and like really being supportive, that we wouldn't know. We wouldn't know until we either got a call from the hospital. If I was on staff, it could admit that patient. If I wasn't on staff, I wouldn't know until they were discharged and coming back into my office. And the fact that it still exists in that manner is really distressing. I think it's an opportunity beyond the ACOs and Medicare Advantage. It needs to be an opportunity for fee-for-service Medicare as well, to really think about what do we need to do so that these patients who are now in the emergency room, then being admitted to the hospital, to a SNF, home with home health, coming to their PCP office 3 weeks later, know and can get that information, because that becomes a huge barrier in trying to get information from 5 different sources. It is a redundancy that I hope that we could solve for. But I will say that in the lifetime of my practicing, has not been solved for yet.
Thank you for that.
And next we'll go to Jen.
Thank you so much for your presentations and a really engaging conversation. I have a two-part question, and I think I'm going to direct it first to Dr. Meyer, but I'm curious to your thoughts on both, and I'll give you my two questions together. The first is, Dr. Breyer, you recommended payment, some recommendations around incentivizing high value care regarding payments. And that's around both the process of screening and then ultimately access, which I interpret as, intervention and treatment. So I'd like to give you some space to describe a little bit more your or the panelists' thoughts around how to incentivize this high value care, around a team that is provider, nurse case managers, social workers, and I assume probably a pharmacist would be added to that team. Is your vision payment would be for the ambulatory space, the inpatient space, facility, provider? Could you just give a little bit more clarity around how to create those incentives regarding payments? And then my secondary question will be then around, I think there's lots of recognition around how important this service is. But I will tell you, at least in my own community in the Rocky Mountain area, there's a huge recognition, but there's a lack of workforce to deliver this care. Although we may have a process for screening and identify patients, it's screening to nowhere potentially. So you can talk a little bit about workforce issues and innovative care models you've seen. And again, I'm going to tie that back to payment. Then how do we incent those innovative care models where there may not be access to these important resources? Thank you.
So I'll start with the latter part of your question, which is that since we don't incentivize use of palliative care, we have a workforce problem. We don't have any workforce problem with orthopedic surgeons. We have tons of them because we incentivize the work of orthopedic surgeons. We disincentivize the work of people in palliative medicine, and that's a policy fix. It's not an advertising problem. It's, if people can't make a living, if they can't work with a team because there's no reimbursement for the team, it becomes, you're asking people to be Mother Teresa. And a lot of Mother Teresa's in the field, but that's not a scalable model, right? And that's what we're relying on right now. In terms of models that identify, there are some bundled payment models and several others that embedded palliative care consultation in their model and attribute their success in improving quality and reducing cost to that embedded palliative care consultant or team. So when the incentives are right, the payment incentives and the quality measurement incentives, and when people are incentivized to use palliative care as a mechanism of improving value, they will. It's really just, it's both the carrot and the stick. We want you to have, a good example is the Commission on Cancer added a requirement for access to palliative care about 10 years ago. The number of palliative care programs in the South and Southwest of the United States increased by 300% within a year because there was an accreditation requirement. We don't have an accreditation requirement for palliative care anywhere in the Medicare system. The only place that it's required is in LVADs, but it could be required much more broadly. When it's required, the resources will be applied, but it isn't required anywhere. The fact that palliative care has grown as much as it has, despite a complete lack of policy incentives for it to do so, is a measure of how desperately needed it is, and that health systems have invested money they're not getting back on fee-for-service in supporting these teams.
I would just add that the evidence is there for why we need palliative care solutions. I think the thing what has always been distressing is that sometimes it's regulated to like a box that's being checked, and it needs to be so much more than that. If you look at cost benefit analysis ratios, and I could bore you with utilization spreadsheets, but when we see active engagement, active delivery of palliative care services, we see that the costs go down. It is a proven model, a proven care delivery service for how to manage complicated patients. And it should never start at the end of life. It needs to start like at the beginning of that diagnosis, and we see the benefits when we do that.
We need some help from government to get the flywheel moving.
I think also that to help support the work that we require in palliative care is to look at codes that pay for the care team. Jennifer, you identified the care team as you went through. Maybe it's truly identifying and mandating that is the care team that needs the basic, let's call it the basic care team. You can add to that, but the basic care team needed for that service, and that the codes are around that team working together, rather than as one provider in that team has to do all the billing and everybody else has to do the service. We need to go beyond a single provider to the broader breadth of care teams that deliver this type of care, whether it's transition, care coordination, PCM. We need to think about it in the team concept rather than the individual. I hope I said that right, Doctor.
You did. Brilliant.
Did you have another layer you wanted to add to that, John, or did that answer your question? Jim.
Sure. I had a question to the entire panel. If we were to kind of wave a magic wand and had a global payment like we do, as the example was used a moment ago of orthopedic surgeons, and there was a model for global payment of a total joint. If there was an equivalent global model for palliative care led TCM activities, and that was rolled out, if that was developed, would you think there's the cost that it would do that we've discussed here today, that y'all have illustrated, the cost of having that complex interplay of services and connection to the PCP, would that cost be covered by the savings? And is that information available? You know, we could do is the actuarial horsepower available to evaluate, like what you would say, this is what this would cost, and we would divide it by this many patients based on capacity. Would that generate enough savings? And has that been is that in the literature, I guess is what I'm probably asking, or if it's not, how would you construct that?
So the answer is yes, it's in the literature. Whether it meets CMS's criteria for adequacy of data, I will tell you that the great majority of Medicare Advantage plans contract with palliative care vendors, so they believe in it. They're these private for-profit palliative care vendors, many of them, that are getting a per member per month payment from the MA plan. So MA plans are voting with their feet on palliative care. Traditional Medicare has not done anything to incentivize access to it. So the question is, what's the standard for making that decision? And is the data standard so unreachable that we'll never get there? And that's perhaps a worry. And the other issue with a care transition or a care management payment model is that it has to be worth the squeeze, and it hasn't been within fee-for-service Medicare. It's a huge amount of administrative hassle, and the payment is not meaningfully equal to that. So it depends a lot on what the payment is.
Yeah, I would add that to your point, Diane, we're doing that. That is something that we're actively doing when we're thinking about the cost benefit analysis. What is it? What is the cost versus the benefit of taking care of a patient and being proactive and engaging that patient proactively with palliative care services? We've recently invested in a home-based medical care model that is going to be able to deliver that palliative care eval and then treatment in the home, because we know that if we want to keep a person out of the ER, we need to be managing them appropriately. And if you're not thinking about all of their symptoms and that the challenges that they may have, that those palliative care needs, then you're not doing that appropriate management. Um, Time and time again, we've seen that model work. It is the basis of the iSNP model that we support through Optum. It is the basis of the IE-SNP models that we support as well. So on the Medicare Advantage side of it, if you're looking for that data of how to do it, there's a lot of resources that the Better Medicare Alliance has put forth, as far as studies that have been done to show that this does work. Now, every Medicare beneficiary should not be on an MA plan. So where we need to figure out is, how do we make this work in the fee-for-service world? We are utilizing a lot of resources on the fee-for-service side, and the reward um, for taking care of a person who is sick on the fee-for-service side is to get another encounter built. And as long as that is the reward, then we're going to still see the same outcomes. So I think it really behooves us to think to be innovative in the way we're thinking about how do we pay the providers. If we're forming a team, what does that look like, and how do we pay them more for the value that they're bringing, instead of just that encounter with those codes, and however many codes you could get on that one encounter so that I could beef up that claim. That is not going to get us to a place where we will see the outcomes that we're seeing on the Medicare Advantage side.
I would agree with what both Diane and I'm sorry, Dr. Meyer had
We're both Diane.
Both Dianes.
I was looking at this and I'm like, okay, they're both Diane. So,
Yeah.
but I can't stress enough where we are with the fee for service, but I also want to take what Dr. Meyer was saying, that palliative care shouldn't be transition, it should be an integration into that. And maybe that is a way to really look at that in the fee for service world, is that it isn't just a handover, a handoff, it's an integration into the care coordination model, but it is a team model that we look at and that we identify. I know that fee for service is so much more difficult, but the fact is that there is extreme cost in that fee for service because it is rewarded by encounter rather than really by the value added or the coordination of the team that is done. So I just encourage us to really look at that and question. I mean, I think it's time to question, why can't we change some of these things that in transitions and care coordination we've been talking about for a number of years.
Very helpful. Larry.
I just have so many questions today. I have to say, though, before my question, this has been a fabulous panel. I've learned a lot from each of you. Thank you very much. My question is about care coordination. And each of the three of you have alluded to it or mentioned it directly in the course of your statements today. And I live in the care coordination world in my real life. And it is very difficult to get a health plan to give us a value-based care program around care coordination. It's not easy. And so I guess I'm going to direct my question, even though all three of you can answer, I'm going to go to the payer representative, Dr. Diane Sanders-Cepeda, and tell me, in the absence of a value-based arrangement, how do you compensate a provider group for care coordination?
So that is a great question. I think that we have been able to stand up those type of relationships where we are looking at what that provider group may be delivering around care coordination, but what I think we've leaned into, because we do understand how difficult it is on the provider side to do that, what we were able to lean into is incentivizing that provider group in the model that we have, where we are sending out our quality field manager to their office to be with their practice manager and look at, okay, these are all the things that they're doing to bring value. Here are all the gaps in care that they're closing, the amount of recommendations that they're doing that are aligned with how we are closing and addressing those star gaps, and then incentivize them with a check that goes directly to their office. We're actually standing up a pilot in Georgia around Z codes, because we want to be able to make sure we're getting in front and identifying any member with a social need or who are at social risk, teaching the primary care physicians, those are codes, and we know they're not the most attractive of codes, but they tell us something where you're coding them. But we understand that the value of that code is low on the radar. So we want to incentivize you directly and incentivize your staff for going through the social determinants of health screenings that we are trying to develop for the population. So in that way, and working directly with those provider groups, we know they don't have to be an ACO to do that. We're just looking for groups who are enthusiastic and willing to do that type of work and lean in with us. Now, what may or may not happen, their structure may change and they may become an ACO with us thereafter, but what we're looking for partners for innovation. We're just looking for enthusiastic providers, and we want to make sure that we are equipping them with those incentives. The other thing that we've been able to do is really have them link up with the care coordination that we are delivering on our end. That's part of our standard program, because we, like I said, time and time again, have seen the value of doing that. So when we have a group who's providing it, we don't want to de-incentivize them. We want to reward them, but then also link them with our teams so that we know how to navigate the care for that individual together.
Walter, you're next.
This has really been a great panel. It's kind of taken a different direction than I had anticipated, but just super valuable information and perspectives. At first, I was going to ask about our panelists' perspectives on how should palliative care be reimbursed under fee-for-service. I think it's clear that there's huge value for palliative care in value-based payment model, but under fee-for-service, though, palliative care takes often a long time, and the financial savings is often in the avoidance of care. How do you value chemotherapy that was never given or dialysis that was never undertaken because of the palliative care consult? But I just don't know how Medicare does that. How does Medicare in the traditional fee-for-service world somehow value palliative care the way it should be valued, the way that Medicare Advantage is valuing it, because Medicare Advantage is taking full risk and getting payment on the backside, or decreasing costs on the backside, and able to apply the savings to palliative care. So that was going to be my original question. I have another question. I'm not sure what time that was.
Well, right now, fee-for-service Medicare does not incentivize palliative care, except insofar as it reimburses hospitals through the DRG. So hospitals are highly incentivized to reduce length of stay, reduce complications. Palliative care is extremely helpful in helping hospitals prevent those long, complicated hospital stays that block beds and cost them money. So to the extent that hospitals are incentivized by, hospital mortality, readmissions, and length of stay and complications, hospitals across the country, 95% of hospitals with more than 200 beds have a palliative care team because of those financial incentives. Not because there's any JCO or other accrediting body requirement. There still is not. And I think that's appalling for hospitals and other entities that there's no mandate that palliative care be available in hospitals. That would help a lot if there was one. But the outpatient setting, it's just Part B, right? And Part B, evaluation and management codes, and some care coordination and some TCM, but you can't make a living for sure, and you can't pay for your team. And this what really makes me nervous is that many of my colleagues are going over to work for MA plans or MA vendors and leaving the fee-for-service system because they literally can't support themselves. And some health systems are not investing adequately. So that's a huge risk to traditional Medicare, that the workforce is going where they can make a living wage.
I can jump into, and I probably talk from the different perspectives, but to Diane's point, if the only thing that I have available on the fee-for-service side is the 99497 type of code, that E&M code, and maybe building a prolonged service code, that doesn't really speak to how you're incentivizing someone to do this work. I think I don't think that, I think there's opportunities to be more creative outside of just the way we're coding. It may take a different structure, but it doesn't have to only exist in the Medicare Advantage space. And I think when I was thinking about how to making a transition, it was really about trying to design clinical programs that actually solve problems, because of that frustration where I could see 40 to 50 people a day, but trying to get the staff paid and try to get myself paid out of that was very burdensome and very taxing. And if you're trying to practice geriatric medicine, is it possible to see 40 or 50 a day? So I think that when we're thinking about those care models that could work, how do you take some of the learnings from a Medicare Advantage plan, and then build up these programs like we've described today? It's not a possibility. It just means that we are looking at valuing that group. If there's a group who becomes the hub that Sherry talked about, and they are doing this work, how do you pay them for the work that they're doing? I think it just becomes about being creative and realizing that that cost avoidance, as was mentioned, is very valuable. Not only to the overall quality of that person's life, it is also valuable if you're thinking dollars and cents and how much money is wasted by the time we get a person to the end of their life in that last 6 months, where we know that their quality takes a nosedive and we're now spending all this money. They're going to having multiple transitions in a month, and no one is having the hard conversations because we don't seem to have it until we're really at the end of life, when we should have had those conversations and really thought about this 3 years before, 4
Right.
years before. And Walter, I might have got it on the soapbox. Sorry about that.
No, I was just going to say, note to ASPE staff. This might be a broader topic to pursue in the future.
I think we'll go to Angelo next to wrap it up.
This may be a short question. I'll start it out directed at Sherry. So there's been a lot of concern about patient copay related to CCM billing. and a lot of that being a barrier to access to CCM. Are you experiencing the same thing, and have you figured a way to get around that? Are you doing Part B waivers, or can we talk about that a little bit?
We actually hear from our providers that often can be a game stopper right in the very beginning if we're telling a patient that they have a copay under Part B for the CCM. I think we tend to forget that many of our seniors are on the fixed income of Social Security. And when you have to talk about a copay, it is a real disincentive. There are issues around waivers, as you know, in the fee-for-service for that. NTAC has submitted comments back to CMS asking that be taken away. It is my understanding under the Medicare Advantage plans, there is no copay for the CCM, which again encourages us to use these things under our Medicare Advantage or our ACOs or IDNs, but tends to stop us in the fee-for-service. As long as and this is heartfelt from me, as long as fee-for-service is the more you do, the more you get paid, we are on an uphill battle to really make this work, which is one of the reasons I think all three of us said, maybe it's time in the fee-for-service world to really look at a team concept and how we might be able to bill for that based on a team. I also think, in all honesty, we need to expand our ability to provide that through providers. As I said, an advanced practice nurse with a nurse, social worker, pharmacist is able to provide a lot of this care, and it doesn't always have to fall on the shoulders of the MD and the DO. I just think we keep making these administrative burdens so great that the administrative side of the code versus the payment is the deterrent right there.
Yep.
Thank you. Anybody else have any comments?
Enthusiastic agreement.
Yep, right there with you.
Perfect answer. Good.
This has been an excellent discussion. We appreciate each of your really important contributions to this. We'd like to welcome you to stay and listen to as much of the meeting as you can. We'd love to have you on. Right now, we will take a short 10-minute break until 2:50 Eastern before moving into our first listening session. Thank you so much for the rich dialogue.
Thank you.
Thank you.
Produced by the U.S. Department of Health and Human Services.